We chose a subject of great resignation because the pandemic started. There is a significant and alarming trend for health workers to leave their jobs, especially in high-income countries, burnout, moral injury, surges in patient numbers, feeling undervalued, a lack of resources to treat patients, having all contributed to the exodus of workers. As a health worker myself, a physician that has worked during this pandemic, I can tell you it's a universal issue, regardless of which health system you're a part of, which type of health worker you are, we are feeling the burnout. A recent report published by the WHO, the World Health Organization, and the World Innovation Summit for Health, WISH, which was titled Our Duty of Care, a Global Call to Action to Protect the Mental Health of Health and Care Workers, found that a quarter of health and care workers surveyed reported anxiety, depression, and burnout symptoms. Women, younger workers, and parents of dependent children were found to be at greater risk of psychological distress. This should be no surprise. Since women are the majority of the health workforce and have been the majority in patient-facing roles in COVID-19, it is not surprising that those leaving and considering leaving are disproportionately women. For women health workers, the huge additional stress of work and on top of the gendered burdens that care within the pandemic women have taken on, such as childcare when schools closed and increased hours of unpaid work. The Great Resignation comes against the backdrop of serious global shortages of health workers before the pandemic. In the US, currently, 31% of health workers have considered leaving the employer. In the summer of 2021, in the United Kingdom, more than 27,000 health staff voluntarily resigned. Again, I'll repeat that number, 27,000 health staff voluntarily resigned, and amid burnout caused by a combination of pandemic pressures and staff shortages, representing approximately 2% of the workforce. Our concern is that the Great Resignation of largely women health workers in high-income countries will lead to a great migration of health workers from low and middle-income countries with poorly resourced health systems already short of trained health workers. So this is going to have a ripple effect. If we are seeing the Great Resignation in our high-income countries, we're going to see the Great Migration, which is going to cripple health systems that are already fragile. In 2021, Women in Global Health was proud to launch the Gender Equal Health and Care Workforce Initiative, which we co-lead with the government of France because we recognize that health systems cannot function without the work of women. At the same time, we recognize that gender inequities in the health workforce, including leadership, pay, and protection, reduce the morale of women workers. The Gender Equal Health and Care Workforce Initiative aims to inspire action for gender equity in the health sector in 4 pillars. First, promoting equal participation of men and women in health leadership. Second, recognizing the value of unpaid work, largely done by women in the sector, and the importance of equal pay. Third, protecting women health workers against violence and harassment. And fourth, ensuring safe and decent working conditions for health and care workers everywhere, including addressing mental health needs of health workers. These are critical areas to address if we are to retain women health workers and make the sector an attractive profession for early career women. I am pleased to note that in just over a year, the Gender Equal Health and Care Workforce Initiative has convened the international community, focused attention on critical issues of gender equity in the health workforce, and we now have over 40 governments, international organizations, and NGOs that have made commitments to express this support. But I also want to say that not only are these entities making commitments, they're taking action. And we are calling on all of you to join us in the initiative and to take action. We want to thank all the governments and organizations that have joined the initiative, with special thanks to a few that are with us here at the summit, Mr. Jagan Shopgun, Secretary General at the International Federation of Red Cross and Red Crescent Societies, who will be announcing IFRC's commitment to the initiative today. And I look forward to our expert speakers today. And now I invite our speakers. First, Dr. Moetti, Director of WHO Afro Regional Office, to please give her perspective. And I will at the same time ask our speakers, panelists, to come to the stage. Please come on up, Dr. Moetti. I will be introducing our other speakers after Dr. Moetti's intervention.
Thank you so much, Rupa. Honorable ministers, distinguished guests, ladies and gentlemen. Migration of Africa's health workers, especially women, given that about 2/3 of the bulk of the health workers, that is nurses, are female, has been a challenge for decades now. There have been some interventions that have been attempted, some promoted around the World Health Organization and resolutions of the World Health Assembly. And unfortunately, these have had limited success. And the COVID-19 pandemic, as has so well been outlined by Rupa, has exacerbated the brain drain. And we're starting to see the impact of this acceleration of people moving already. For example, in Zimbabwe, more than 1,200 nurses resigned, potentially to emigrate in 2021, which was 3 times the number that had left in 2019. And Ghana has recorded a 43% increase in the resignation rate of healthcare workers in 2021 compared to 2018. So as it has clearly been said, clearly the COVID-19 pandemic's impact itself had something to do with this, but we know that many of these healthcare workers will also be leaving to find opportunities in other countries, the countries where the great resignation is apparently happening. So in the past, recruiting countries, mainly upper income countries, compensating source countries has been tried with really very little success. So these were agreements that were reached among member states in the World Health Assembly and in organs of the World of WHO, and it simply did not work to get that equitable, fair compensation for the benefit of workers migrating from low-income countries from the wealthier countries. We know that in countries with fragile health systems, migration impacts the ability to provide basic health services and have effective primary health care. We know also that it probably delays the early detection of outbreaks and epidemics. And who do we find in most of our countries at the most peripheral level? It is nurses, it's mainly women, and the conditions under which they work is something that we're going to be discussing today. We've seen, for example, I'm certain many of you are aware that there's an Ebola outbreak in Uganda at the moment, which continued for a couple of months in a peripheral area before it was detected. And we know it's because that we do not have the capacity at that level where normally a community health worker or a nurse should be able to see that something strange is happening in the pattern of disease among patients that we're seeing here today. That is not yet in place. So I think we might think about equity, the availability of healthcare workers, not only as something for the country in which they reside, but in relation to the relationship with outbreaks as almost a public good. If outbreaks can continue and spread in a corner of a country, they can easily spread to the rest of the world. And that's something that we've been dealing with dramatically in the last couple of years. So despite the adoption of WHO's global code on the international recruitment of health personnel, the dependence on foreign trained health workers by high-income countries has heightened, and it will only get worse now that we are discussing this phenomenon. That's the theme of our meeting today. Of the 47 countries that WHO classifies as needing safeguard and support against aggressive, unethical recruitment, 33 are in the African region. So this is a particular concern for our region. It's also a great concern that some of the health workers who leave Africa are settling for jobs abroad, which are sometimes well below their skill set, particularly we know in the adult and social care. So the protection of the rights of migrant health workers is also key to avoid exploitative and abusive conditions of service. I'm sure you've all seen the recent BBC article that highlighted how African migrant doctors are being forced to work unacceptably long hours. And there have been other reports of recruitment agencies using bonded labor schemes to take almost half of the earnings of some of these health workers recruited from Africa. So that's something else that needs looking at, particularly because most of these are nurses and are women. Safeguarding Africa's health systems, especially primary healthcare, as I said, offers our best chance of achieving universal health coverage. And we are aware that African countries have tried to invest more in health workforce training in the recent past. In the 13 years prior to the pandemic, Africa achieved a threefold increase in the output of trained nurses and midwives. And African countries increased the output of new doctors fourfold and produced 170% more trained community health workers. We have to acknowledge again that the community health workers, most of whom are women, are paid very low wages, are working under very uncertain conditions, and that's something else that needs to be addressed because they could potentially be a huge resource for primary health care and for health development, at least in the African region. So despite all these efforts, the region has a shortage of 5.3 million health workers, and African member states need to urgently increase health workforce spending on employment and retention by 40% on 2020 levels, as well as improving the conditions of work. I'd like to also encourage our development partners and international financing institutions to view health worker training, employment, and retention as a worthwhile investment. As I said, I think it's in everyone's interest, including in guarding against our collective vulnerability to disease outbreaks. The issue of endemic gender inequity is critical and central to this discussion, as women account for 70% of the global health and social care workforce, with the financial value of their input estimated at more than $3 trillion annually. Yet they still occupy only 1 in every 4 top healthcare leadership positions, while research suggests they routinely earn 20% less for their efforts than their male counterparts. They also work in the most challenging environments, as I've said, at the most peripheral levels in many healthcare systems, at least as far as the African region is concerned. So gender policies are crucial. I don't want to repeat what you already said, Rupa, to address the inequities, the systemic inequities in earnings, to remove barriers to full-time employment, and to support access to professional development and to leadership roles. Increased representation of women in top leadership, in ministries of health, in other decision-making organizations, in health initiatives and programs will also help advance gender equity. All member states should prioritize increased spending to train, employ, and retain their healthcare workers. In addition, recipient countries of Africa's health worker migration should commit to invest in the training of additional health workers to sustain the health system of the source countries, addressing the gender inequity issues as well. And then finally, really, the conditions of service of migrant workers, including the gender issues, do really need to be addressed. Thank you very much, and I look forward to our exchange on this very important issue and the follow-up work we'll do together. Thank you very much.
Thank you, Dr. Mohamedi. A very clear call to action and a reminder that we've already been hearing in today's session is how interconnected we are. So the fact that Africa has done an incredible job, I think, recognizing the amount of training that has happened, an increase across all the health workers you mentioned in significant numbers, and yet there is an issue of migration that is causing destabilization, and that we also know that these areas have to be looked at from a gender perspective, and you're calling for gender policies across the board when we look at health workers and how we support, train, and take care of them. So again, thank you, Dr. Moeti. We look forward to engaging you with this initiative. I'd like to next introduce all of our panelists, and I'll be turning to each one to chime in at that point. We are joined by esteemed Honorable Excellency Dr. William Jala, who is the Minister of Health for Republic of Liberia. After that, we're joined by Mr. Joggin Chapin, who's the Secretary General of the International Federation of the Red Cross and Red Crescent. So welcome, Joggin. Then we are also joined by Dr. Lourdes Capetillo, obstetrician and gynecologist from the International Federation of Gynecology and Obstetrics. So again, welcome, Lourdes. The next part, we are going to have a panel aspect of it. So I turn to you, Minister, to hear your perspective.
Good morning to all, or afternoon to all. I bring you greetings from the Republic of Liberia. Our president, President George Manawia, who is a feminist in chief. He has 5 women leading large ministries in the Republic of Liberia: agriculture, commerce, gender, public works, and the Ministry of Health. So I think he's doing well in terms of gender equality. Just again, as we begin, we see that again, you're hearing Africa must prepare. During the beginning of the epidemic, we heard Africa must prepare. Now again, we're hearing Africa must prepare. Looking at Liberia's situation, we can see that after the Civil War and the Ebola, the number of healthcare workers decreased significantly, lost because of migration and deaths and other things. Today, the number of healthcare workers, we have 12 per 10,000 health population. And so we're far below the number considered by WHO. Now, what is happening? Why is there an issue? We have been training healthcare workers in the public and private sector, but because the inability to put them on payroll, so we have a high number of healthcare workers that are trained, sitting or coming to facilities and acting as volunteers in these facilities. So therefore, we are not right at the moment experiencing the migration out of the country, but we are experiencing attrition of healthcare workers from the various facilities because we have a high rural population. And a lot of the healthcare workers, once we send them to these rural areas, they stay there for 10 years, 15 years, separated from their families, low wages or poor amenities, no housing. And so they get tired and they leave those areas to come to the city. Then the volunteers who have just completed school are all trying to get on the payroll. And so you have that imbalance going on. But for us, as we prepare for this, we know that because of the low wages, we know that because of the poor amenities that our healthcare workers are receiving, we know that any opportunity to migrate will cause them to resign. So what we have done as a government, we put together already a multi-sectorial team that includes labor, gender, justice, and the Ministry of Health to look at laws that will protect our citizens as they are migrated. We all know what's happening with trafficking of people outside of the country, their ill treatment, and all of the problems they are facing in all of these countries. So we want to make sure we have policy in place. We have the nursing board, the midwifery board, and other boards on the table sitting to be able to organize what will happen to our people if they want to leave. The pay, where they are taking them, whether their families will be allowed to go with them, what kind of training they will be giving them, and to make sure that that training come across to the rest of the healthcare workers, so that when other goes, we have still have trained members to be able to take care of the current population that we leave behind. We also have joined the Gender Equity Initiative to make sure that our female workers are treated well. We wanted to know, we did an assessment to know the biases, the reason why we do not have a lot of female workers in the different categories of care. And so the assessment showed us that in the cultural sense, women are supposed to be the caregivers. They are supposed to remain home. They are supposed to have the children, but the men's supposed to be the breadwinner. So we're trying to address that issue, putting women in leadership position, making sure that they too are the breadwinners of their families, making sure that the population understands that women can do equal work as the men, and they deserve equal pay and equal amenities as they go along. Thank you.
Dr. Jala, you have given us a very concrete example of how you're working on the Great Migration and the Great Resignation and Great Migration even within your national borders. So I think that is also very important for us to reflect that migration is not always out of the country, but within the country, within professions. And then you also highlighted why it's important that these conversations don't just happen within the Ministry of Health, but very commendable of bringing other ministries together to solve this issue as a core aspect of addressing the health system and broader development. And another thing that really stood out about your example was the fact of capturing data and doing a gender assessment. So these are all such great examples of the important work you're doing, and we really appreciate you being in our initiative and taking action. So now I invite Dr. Jagan, please, the floor is yours.
Thank you. Thank you, Rupa. When Rupa invites me for these events, I always accept it very easily because this is a rare opportunity where gender-wise I'm in the minority. Mostly it's the opposite. So thank you for having me. First of all, I fully support the 4 points you outlined, Rupa, and I'm really looking forward to work together with you on how we can join forces to advance some of those topics. And by the way, those were my talking points also. So we are fully aligned here. I think the absolute commitment to equity, as Minister, you also highlighted, I think that's very, very important for us to advance this agenda. I think Minister, you highlighted the need to have a whole of government approach. You cannot tackle this issue in isolation. Fully support that approach, and also need to have a proper legal framework to address some of these issues, because without a legal framework, it's very difficult to sustain the change. So I fully agree and I fully support, but I would like to bring a slightly different angle in this conversation. I think, Rupa, you highlighted already the numbers around the resignations and migration, and I think these numbers speak for themselves. I think there is no need to repeat that. But I would just like to share another number with you here. When I saw some of these numbers of resignations and migration, once the COVID-19 started, we also have been tracking how the community has been responding to COVID-19. And in my organization, we had generally roughly 14 million volunteers globally before the COVID-19 started. And during the COVID-19, that number actually increased by 1 million. So what we saw globally was the increase in number of people who actually wanted to come forward and volunteer. And what we also found, and we have been tracking the data, that during the COVID-19 peak period, we had about 1 million volunteers on a daily basis, 1 million volunteers on a daily basis going out to support the national health efforts, supporting the efforts of the health ministries, the hospitals, and the general health system. So when I saw these two statistics, I think there is something missing here. And also, Minister, I want to share with you, and actually my predecessor and my mentor, Elhaz Assi, is here in the audience. When Ebola hit, and the countries, the Sierra Leone, Liberia, that time hit very hard by Ebola, and when the health system was stretched, and one of the biggest challenges there was actually how to bury the dead in a dignified manner, because that was the main source of transmission of Ebola. And that's when actually he championed that why don't we mobilize the Red Cross volunteers who are generally trusted by the local communities and actually ensure safe and dignified burials of the people who died of Ebola. Now that experience, actually, we took it to DRC Congo when DRC was hit by Ebola. And now we are offering the same experience as Uganda faces the same crisis. So you see the community volunteers, the volunteers like Red Cross, but not only Red Cross, many other organizations have volunteers working at the community level, could be a massive complementary support to the national health system. Let me give you a very practical example. Last year, when the vaccine started getting delivered, South Sudan got vaccines, 60,000 doses of vaccines. And probably you saw that most of those vaccines got wasted because those could not be utilized. Because the national health system was already stretched. A lot of the community health centers, those of you who have been to the ground, are mostly, one health professional, maybe supported by a couple of nurses. They have no capacity to mobilize a vaccination campaign. How do we actually go mobilize the community, register them, organize the vaccination in an orderly manner, and actually also ensure that the people come back to take vaccines? Unlike in Switzerland, where we had everything in app, in most of these communities, they don't have that. They have to be done on manual basis. And that's the type of work the community volunteers can provide, and free the health worker from the stress of organizing, mobilizing, and following up in a way, because their time and expertise could be used in a very different way. So my proposal here is, I think we need to find a way to better connect the community health volunteers, community health system with a formal health system in the countries. That will go a long way. It may not solve all the problem. That will go a long way to reduce the stress and the burnout the doctors and nurses and midwives are facing at the moment. And I think I really call upon the governments to invest on the community system. I give an example of South Sudan, but I was in Canada 10 days ago. In Canada, health system also was stretched. That's the story that was told to me. And the Red Cross was asked to mobilize their volunteers to actually support the health system of Canada, very wealthy and very developed health system, the country with a very developed health system. So let's not forget to invest on the community health system and basically make them complementary to the national health system.
Thank you, Jagan. But Jagan, since we know each other, I can also push on a point too. And this initiative, one of the key pillars is about pay and compensation. So your point about, looking at entire society. So we had whole of government from the minister. We're having whole of society in a way to really say, how do we mobilize? And the mobilization you're talking about is in times of crises, but also in times of stress health systems. But you also said one very key thing that I want everyone to pick up on. It's not just about volunteering, but it's about a better way of volunteering, a better way of the volunteer system complementing. Because we know Women in Global Health just did a report that we released in the summer that at least 6 million women health workers have been unpaid, underpaid, and they're striking because they are not supported and not protected and not having the services, and they actually want to be compensated, and they want to see that their volunteer pathways can lead them to a career progression. So I think that the point here is that as you think about volunteerism, how do we ensure the better way and then the better way between the health systems? So I think that's a challenge for us and all of us in this room, but I think for you as a partner joining this initiative to seek through with us.
No, absolutely. But I think it's also very important to differentiate the people who come willingly to volunteer versus the people who are actually working on the way you described. Huh? So the volunteers, this 1 million additional volunteers who joined, they have been having other jobs. They have been having, but they want to come forward at the time of crisis to offer the solidarity. And we absolutely do not want to lose that, because that's very important part of the societies. How do they work? How do they function? And also it's extremely important. And many of the volunteers I have met myself, one of the reasons they say they volunteer is it also helps them. It's also a massive way of connecting, staying in touch, and also a massive way of psychosocial support to themselves. We absolutely don't want to lose that either. Huh? So yeah, that's an important discussion we need to have.
And a lot of commonalities. We in the Women in Global Health movement are volunteer fueled. people have jobs, but they want to also contribute meaningfully. So I think this is a way how we can take the topic forward in the pillar and really look at pay issues, but also look at how we mobilize society, and your organization has done this important work for decades. We look forward to welcoming the learnings and sharing it across the initiative partners. I'd like to next turn to Dr. Lourdes. You are one of the health workers, and we really, turn to you to give us a bit of, the experience that you are seeing from your community on this topic of Great Resignation. The floor is yours.
Good afternoon. Thank you. I'm very much honored to be part of this distinguished panel of speakers. I'm a FIGO representative here, but I was invited to talk about the status of nursing and healthcare workers in the Philippines. So in my country, 74.1% of nurses are females. Of course, there are some males. Our country is also one of the largest supplier of nurses to the OECD countries. That's the Organization for Economic Cooperation and Development. We have an outflow of about 15,000 to 20,000 nurses per year, despite shortages in our own health workforce. The migration rate for our nurses is 71% per year, with about 316,000 working overseas as of December 31, last year. Thus, it is not only the great resignation that our country is facing, but also the great migration of our female healthcare workers. During the first 2 to 3 weeks of October 2020, 5 to 10% of nurses in private hospitals resigned, and this rose to about 40% during the height of the pandemic. Most infections during the early months of the pandemic were also found among doctors and nurses, mostly due to lack of PPEs during this time. Such shortage, unfortunately, forced many healthcare workers not to eat or even go to the toilet during their shift just to reduce the usage of PPEs. They even experienced harassment as they were tagged as virus spreaders, especially in the early years of the pandemic. Women healthcare workers in particular are at higher risk of mental health symptoms compared to men. Being a frontline female health worker in our country is associated with worse mental health outcomes and higher rates of severe depression, anxiety, and stress. Gender inequalities were also amplified during the pandemic. Women in my country were working 2 shifts. The first shift was their work in their hospitals. The second shift was domestic care, attending to household needs with the challenge of reduced resources and supervising children's online learning. In this situation, women bore the brunt of unpaid care and unequal distribution of labor and domestic work. Our government tried to address the problem by issuing a deployment ban, preventing our nurses from leaving the country for overseas jobs. In return, it granted an additional $10 allowance for nurses, but distribution was compromised, leading to mass resignation of nurses in the government hospitals and many seeking other employment rather than nursing. The present government, it's new, is addressing the problem of resignation and migration by releasing about 25 billion worth of benefits to health workers, including hazard pay, COVID-19 sickness and death compensation, meals, accommodation and transportation allowances, life insurance, special risk allowance, and the one COVID-19 allowance. The deployment ban has also been lifted, and the president is seeking to increase the deployment cap from 7,000 to 7,500. That's more nurses being able to work abroad, while at the same time striving to improve domestic opportunities for nurses. So we hope that will come to fruition, this being a new government. And at this point, I'd like to acknowledge the presence of our modern day heroes, nurses from the Philippines working abroad. They kept the economy afloat, especially during the pandemic years.
Thank you, Lourdes. I have to say, another round of applause. We will be announcing tomorrow Lourdes as one of our heroines of health, and thank you for your contributions to health during this time.
Thank you.
While we've applauded, I also want to recognize, Lourdes, there is a lot of depth to the examples that you were giving and the fact that women do have these multiple shifts that they
Yes.
take on. And some of these are heightened during the pandemic. We know for many of them, it's still continuing and has been a part of their life. And so that really pushes the great resignation. And so making sure that there's policies that address this, it sounds like that is clearly the way that you're approaching your work and your advocacy. And for all of us to see that what happens out of the formal aspect of the health system and the households is also critical. That mental support to our health workers needs to factor in the people they are, the gender they are, and what is really the challenges that they're facing. So again, thank you for driving that message home. I want to thank our first round. Please don't leave the room. We're still continuing the discussion, and those that are tuning in virtually, I want to do another round of applause for our first round of panelists. Thank you for joining us, and I'll be inviting our next set. Thank you. I'd like to invite Dr. Rana, Dr. Howard, Dr. Patience, and Dr. Sandra to the floor, please. And for those of you that are tuning in virtually, we invite you to use the Q&A function in the Zoom chat. We will be getting to questions. And for those of you in the audience, we will try our best to get to interventions and questions from the floor.
Great.
Thank you.
Mine? Thank you. Yeah, this one.
So as we dive deeper into the topic of great resignation, we have another series of esteemed guests and your challenge to continue the discussion here. We are joined today by Dr. Rana Hajij, the Director, Program Management of the World Health Organization, Eastern Mediterranean Regional Office. We're also joined by Mr. Howard Cotton, Chief Executive Director, International Council of Nurses. We're also joined by Dr. Patience Afalani, Assistant Professor of Epidemiology, Biostatistics, University of California, San Francisco. Welcome. We're joined by Ms. Sandra Oires Torres, who's the International Confederation of Midwives and also part of the Women in Global Health Chile chapter founder. She is a heroine of health from previous years too. So really, delighted to have this panel. And the challenge is for us to take the conversation forward here. From your perspective, beginning with you, Dr. Rana, you're seeing evidence of the great resignation of health workers. And what do you think is motivating health workers to leave their countries and not just the problem, but as you see some of the solutions too?
Yes, thank you very much. Good afternoon, colleagues, and thank you very much, Rupa, for inviting us to be on this panel. This is really one of the major crises we faced during the COVID pandemic, and also one of the main areas in terms of building health systems that we need to focus on more. I would like to add to what my colleagues have mentioned earlier on. In our region, it's not just about resignation, it's about migration of healthcare workers, in particular women, female healthcare workers from low-income countries or countries in crisis to other countries that are upper income countries. Of course, in our region, we have about 80% almost of our nurses are women versus 35% of doctors, actually. So this is one of the regions where we are trying to increase the proportion of female doctors, but women overall constitute almost 2/3 of the workforce in the health sector compared to 40% or so in the overall sector. So it's a major actually drain on the health sector to see nurses leaving. You know, the main reason we are seeing this resignation from their at least current countries to go to other countries has been two main reasons: the economic situations in many countries in the region that have faced significant economic crises over the last few years. I mean, many of these economic crises were kind of concomitant with the COVID pandemic, but also the insecurity and lack of stability in many countries in the region. We are the region with the largest number of countries that are in some either acute or chronic long-term emergency. You know, we're still trying to sort out the data. So but we have some data, for example, Lebanon. Recently, we have some data from the Order of Nurses where they estimate about 30%, 1/3 of their workforce had left the country just over the last 2 years since the economic crisis. Typically, they go to countries within the region often, or to Western countries because of a better pay. The other major reason for our also healthcare workers leaving has been attacks, unfortunately, on healthcare settings. So in our region, we have the highest number of violence and attacks on healthcare workers and medical facilities. I would quote that in 2021, there were 358 such attacks documented. These are the ones just documented, which represented 44% of the total global of attacks on healthcare workers. So, of course, you know, this has had significant effect on retention of health workers, you know, but of course, the other main reasons have been the low level of pay, the social benefits, and of course the increased stress that women had to, in particular, women healthcare workers had to suffer from, both because of COVID, but because of the added burden of providing care. I've heard a lot of people mentioning providing care, of course, to children, household, but also providing care to elderly has been one of the main things for women, providing care to elderly parents. I've been around many countries in the region, and I saw women staying in the hospitals, actually, especially during the early COVID pandemic, before vaccines were available. They would stay in the hospital for months at a time, sometimes 3 months, because they were afraid of going home and exposing their elderly parents or other. So that's been a huge also impact on mental health of our women healthcare workers. So thank you.
Thank you, Rana. You touch on, you know, critical point here is that there are some universal aspects that apply in every context, but there's also regional aspects as well. And the conflict is a real issue. We're seeing conflict grow in many parts of the world, on the continent that we're in as well. So I think there is a lot to understand and to unpack. I want to come back to you on this one, is that we know that the rights of health workers to migrate and to be able to go for better opportunities is a right itself. But we are also here to achieve the right for health for all, the rights of the communities to be able to get the quality, affordable healthcare, the universal healthcare agenda. What role do you see for governments in this balance, right? If you'd like to chime in, Rana.
Sure. Yeah, of course. I mean, the governments have a major responsibility to maintain, to retain the health workers and to give them opportunities for also career progression and increasing benefits. We've been working with countries in our region to try to implement as much as possible the code. Also, you know, there is an international code, the International Recruitment of Health Personnel. That's a code between both the countries of origin as well as the countries of destination, actually, that there should be regular interaction between these governments so that they don't deplete especially countries that have a shortage. We do have few countries in our region that sometimes are overproducing healthcare workforce, and sometimes it becomes difficult to ensure adequate employment opportunities for all. But for many countries, they are suffering from a significant shortage, as you heard already, while many of their actual workers are leaving. So there should be, countries should have the right strategies in place. Every country should have a national strategic plan for human, health, human resources and health development, so that first, they have their full mapping. They know how, what the areas that need more development or increased staff. But also, this should be a multi-sectoral dialogue. This is not just even for the Ministry of Health, for example. There should be a discussion between Ministries of Health, Ministry of Labor, with the professional associations, to better understand the needs of the healthcare workers and how best to retain them in the country, in addition to addressing all their other needs, other than the professional needs, the other personal needs and other mental health and other issues.
Thank you, Rana, for that point of view. And I think we are hearing some of the themes we've heard already in the first session, multi-sectorial conversations. I'm really glad that you brought up the point about engaging professional associations. So I'd like to turn to Howard next. Howard, ICN has done incredible amount of gathering data, real-time data, both the stories of the challenges that nurses are facing, but also quantifying it when there were just gaps in other places. So your association has been stepping up during this pandemic, but even before then. And I want to turn to you to share from your perspective, on the Great Resignation. What are you hearing? What are you seeing? What's the latest?
Thanks very much, Rupert. Delighted to be here. Greetings from the International Council of Nurses, our president, Dr. Pamela Cipriano, 28 million nurses around the world. I am one, but I'm only 10% of the global nursing workforce, 90% of which are women. Other people have talked about the huge physical and mental health toll that the pandemic has taken on the nursing workforce. And as you say, we've reported extensively on that. Just in terms of some numbers, infection rates amongst health workers at the early stages of the pandemic is between 10 and 20% of all infections. 180,000 we did deaths, we believe. We did work with WHO. I think that's an underestimation. I think it's more likely to be about 250,000. Think about that. Where was the public outrage? Where has been the public outrage on 180,000 at least healthcare workers dying? Compare that to another sector, to the airline industry. What would happen if planes were falling out of the sky on a weekly basis and there were that number of deaths? Nurses who had chlorine thrown over them for people who were fearful of that they were vectors of disease, nurses unable to get child care, unable to renew their rents because of the stigma and the discrimination that they faced, nurses coming off shifts and facing the wrath of the anti-vaxxers saying it's all fake, whereas they've just come off shifts where they've been caring for dying people. You can see a direct line, I believe, from the anti-vax campaign and some of the aggression that we've seen against the health workforce. The mental health impacts, we call that the mass traumatization. Other people have talked about that, but let's go to some root cause issues here. We know that we went into the pandemic 6 million nurses short. There's about 28 million nurses around the world. That's 20%. You imagine in your workplace being asked to face the greatest challenge that you've ever faced in your work, but you start 20% down already. The numbers that we've looked at in terms of the impact of the pandemic, we've called it the COVID effect, combined with the aging of the nursing population, I believe we could be looking at having to replace nearly half, 12 to 13 million nurses over the next few years. And it's not just to Rupert, the latest that I'm hearing just last week, I was with associations from across Europe. We'd seen the evidence earlier this year of nurses later in their career who were leaving the profession. What I was hearing last week was early career and mid-career nurses also leaving. It's not just those nurses who are coming close. It's earlier on their careers. But these shortages, root cause, that's not by accident. Those are deliberate decisions not to educate enough nurses and indeed other healthcare workers. Why is that? I think one of the reasons for that is the historic lack of undervaluing of the work of nursing, and that is deeply rooted, in my view, in the fact of it's being a 90% women who nurse. We all hear people, they'll talk about the care of nursing, rightly so. Do they talk about the courage of nursing? They'll talk about compassion, rightly so. Do they talk about the complexity of what nurses do? They'll talk about the art of nursing, but do they talk about the science, the technology, the leadership, and the fact that nursing is safety critical? The most recent report that we had from the World Health Organization for Europe showed evidence that we know for other regions to be the case as well. The lower number of healthcare workers and nurses you have, the higher the level of patient mortality and untoward incidents and trips and falls and infections. And we heard earlier about the early detection of infectious diseases. So the case for investment, for educating more in terms of public health, public protection, public safety and security is absolutely overwhelming. Why hasn't that taken place? Why has that political choice not been made? And I think gender is a factor at play. And then just to touch on migration, because again, to go to some root cause issue, you haven't educated enough of your own nurses, and there's 6 or 7 countries who account for about 70% of the aggressive migration that we are seeing around the world. So those countries haven't educated enough of their own healthcare workers. They're effectively outsourcing their education costs to other countries. I have yet to meet somebody who says, we don't abide by the global code on migration. We do it ethically. Everybody says they do. How do any of us in this room know that they do? Where is the assurance system? Where is the hard evidence? Where is the data? If we thought about this like climate change, where we offset the things that we know are bad and harmful to the environment, we could do that with nursing. If you're going to go and recruit from other countries, one example, the UK is just now signed an agreement to recruit nurses from Nepal. The UK has a ratio of about 80 to 85 nurses per 10,000 population. Nepal, 20 nurses to about 10,000 population. UK currently has more than 600,000 nurses, Nepal about 60,000. But they are compliant with the global code because they have a government-to-government agreement. I think it's a crafty escape clause to get you to enable this to happen. The code is not, global code, in my view, is not fit for purpose. It has not kept up with the scale of migration, the fact that anybody can set up as a recruiter with a mobile phone as well and hire people from around the world. I think we need, much stronger teeth in relation to the global code.
I have to say, ICN, Howard, you every time I have any of your speakers, share, it's always a call to action. You've heard it loud and clear here. There is a great migration happening. There is a great resignation. The two are interlinked. Many of our panelists have already talked about it, but the current code is not good enough. There isn't transparency. There isn't accountability. How are we going to make sure that this conversation, which is interlinked, it's not just a national one. I think we heard the regional aspects. We've heard now the global aspects. And now I turn turn to a technical expert who has been really studying this. And Dr. Patience Falani, I'm really excited you're on this panel because we share a common origin. I'm from San Francisco too. So, coming and doing your research in that space, I'd like you to chime in on some of the issues we're discussing. What's the latest data that you're seeing, and what should we walk away with?
Yeah, thank you very much. And it's a pleasure to be here as part of this esteemed panel. So I think the question on whether the Great Resignation is happening has been answered, that we know that it is happening, right? We know that it's happening in different ways in different countries. So in high-income countries, that people are resigning and moving on to other professions. In low-income countries, people are leaving and migrating. I think one important thing to remember also is that often not everyone has the social capital to resign or to migrate. And so we are having a lot of healthcare workers remaining who are very dissatisfied with their jobs because they can neither resign nor migrate. So early in the pandemic, we launched this survey initially only in Ghana, and then subsequently included Kenya, really looking at healthcare workers' experiences during the pandemic. And we're interested in experiences around the satisfaction, job satisfaction, but also stress, burnout, preparedness. One thing we found out was that 1 out of every 3 healthcare workers who participated in the survey said they were dissatisfied with their jobs. We had about 2 out of every 3 healthcare workers experiencing some degree of burnout, with almost a quarter experiencing high burnout, which we would consider clinical burnout. So job dissatisfaction and burnout were really high in this population, in both Kenya and in Ghana. We know that healthcare is a really stressful job, but there are certain things that can be done to prevent people from getting to that point of burnout. And in this study, we found out that in the context of the pandemic, that helplessness of not being prepared to deal with the situation was a major cause of burnout. That many healthcare workers simply felt unprepared. In terms of the world was not prepared, right? That we didn't know what was happening. But then they had to be on the front lines trying to figure out what to do. And that was a significant source of burnout to them. And that is significantly contributing to this. So some surveys put it at about 1 out of 3 healthcare workers are leaving because of burnout. They are leaving their jobs because of burnout. And I'm also bringing back to the point on the fact that if we have many healthcare workers who are burnt out, who are dissatisfied and can't leave for several reasons, and we know the implications of burnout on quality of care, thinking about the quality of care we are delivering to the population, right? And also thinking about the implications of burnout on just commitment to the job, that if you can't leave and you are not committed to the job, the kind of care you are delivering. I should say I started this research, actually. My research prior to the pandemic was looking at person-centered care, especially in maternal health, looking at patient experiences. And one of the things we realized was you can't talk about the patient experience without the provider experience. That in order to improve patient experience, we really need to pay attention to provider experience. And so in the context of this whole conversation, think about the fact that there are lots of providers who are having really terrible experiences in the workplace and they are unable to leave, right? And so our patients are having really terrible experiences because this has been passed on to them. And I'd like to stop here, but really just highlight this, that we need to be thinking about those who can't leave, because that is really important also in this context.
Thank you, Dr. I'd like to turn to you, Sandra. I mean, there's so much you can touch upon, but one perspective is coming from a profession of midwives. Do you think there's a difference for women health workers? And then can you share your own examples, what's unique from that gender perspective?
Well, I think we've already talked about all these, situations that we're going through. I think it's really terrible, and it's, I mean, you cannot stop to feel really overwhelmed because all these things that we are relating, regarding all the health workers, nurses, doctors, midwives, all around this summit that we're going to be talking about. And of course, us as midwives have been going through the same situation. This resignation is also touching all of us, especially in the first world, I would say, where many midwives have also decided not to go on with their jobs anymore for the same situations as you're describing, And also in Latin America, for example, in the countries also, I think that there's some other things that maybe are not happening here, but also it's regarding how the society is also feeling towards the healthcare, and how the communities also are not, in some places, not so close to their healthcare communities. So that's also a challenge that we've been living through the pandemics. And even, some places, some healthcare workers have been mistreated, by the same population, not just because they were going to infect them, because just people was, of course, having its high percentage of mental illness and stress during COVID. And of course, right now it's a pandemic of mental illness. And no one is taking care of that. And of course, we're just into this. But there's some other thing that maybe we also have to reflect, that of course, because we are many women in this healthcare workforce, most of us, midwives, nurses, doctors, also we have some other challenges. And usually we are, of course, health workers, but at the same time, we are women, we are mothers, we are sisters. We also take care of the old people, especially in Latin America, of the old ones, our parents or grandparents. And there's been some situations during pandemics, for example, that have been really, really stressing for women, that they even have commit suicide. Many women in the hospitals, for example, Latin America, because they cannot take it anymore. Many women are in charge of their houses because the men are not there anymore. They leave. So they have to take care of the children, the mother, the grandmother, and they have to go to work also. And also because the salaries are low. So there are so many things besides just, leaving the health workforce. I think it's a matter of deciding what should I do. I mean, can I stay here at home and take care of my family, or otherwise it's going to fall apart? Or should I go back to the hospital and take care of my patients? But I think that's here we are here, gathering together because we need to find an answer. We don't have to just be sitting here, because we already know all these things are going on, but we really have to get together and try to stop this from happening. We know that we are many women, but we have to find the answer for that. And one of these would be, starting to work in this enabling environment. We really have to have this enabling environment for women that is going to work, but not just in the hospital or in the antenatal care clinic, but of course, in the press service, for example, when they're at the university, because we also have this high rate of students also leaving the universities, because they're, of course, stressed. They also have this mistreatment sometimes, sexual abuse, whatever. We are having so many things. And I also think that we have to also work very hard, not just for education. We also have to strengthen regulation of the profession, different professions, nurses, midwives, doctors, and also, of course, the association, that is really important, because that's a way that people get together to move forward their goals. And of course, one really important thing that we have to put in the center is the interprofessional work. I think once we really respect each other, we see each other as a team, especially for us midwives, that we are 1,900,000 in the whole world. 1 million are associated with the International Confederation of Midwives. The lack of midwives is 900,000. We are so small, but we are so specialized. So we really need the space to work very good. And I mean, the way that we've been doing it right now for 100 years in the Confederation, and we really need support. There are some places where even midwives, we have the lack of midwives, but there are some other healthcare workers trying to take their places. This shouldn't be happening right now. We really need to support each other among this healthcare team, because we are all needed now. We know that we have this shortage of healthcare professionals, so we really have to support each other, to support the communities, to support the women in our case, and the families, of course.
Thank you, Sandra. We've heard from our panelists here that truly the system is stressed. We also know there's so many competing priorities. Our associations here on the floor are saying this must be a priority. This is not an optional issue. It is an essential issue. If we are to have functional societies, we need functional health systems. To have functional health systems, we need to have health workers that are supported. The gender aspects must be addressed. And top of this is the Great Resignation. It's happening actively. It's not something that's coming in the future. It is here. It is affecting all stages. Sandra, you pointed out young people, students also facing the burnout too. Other panelists talked about the different stages we're seeing this. So this is a real issue. So I want to turn to the audience here and open it up for you to react. You're welcome to ask questions to the panelists here, but also, turning to all of you, how do we make sure this is central to the conversations that are happening in other rooms here in Berlin, but rooms that are all around the world? And we know that there's negotiations for the pandemic taking place. Are health workers and supporting health workers part of those negotiations? I can say not enough, right? If we look at what's coming in the horizon with a universal health coverage, revisiting the political declaration, and next year with the next high-level meeting on that, revisiting sustainable development goals. We also know there is an active, pushback on the gender agenda with particularly sexually protective health and rights. And Sandra, I'll come to you to chime in on that moment. So all these challenges, and this is health workers are a core building block to health systems. So the floor is open. If I see some hands,
Wow.
What I'm going to ask is please keep your intervention very short and to the point, and your introduction as well. So I'm going to make sure we get folks around the room. I see this person right here. If you could please say your name, your organization, and short intervention.
Good afternoon, everyone. My name is Floro Cobello. I am a senior lecturer at the Oulu University of Applied Sciences in the northern part of Finland. Dr. Lourdes, in one of her talk, she mentioned about Philippines as one of the largest exporters of nurses abroad. And one of the current trends of migration and recruitment is that high-income countries recruit registered nurses to work as nursing assistants. So it results to the phenomenon of descaling. And my question is related to that. Do you consider this as an ethical method? And the second question is related to deployment ban. Do you think that this is considered as a good national strategy to prevent greatest migration of healthcare workers from the source countries? Yeah, anyone can answer with my question.
Thank you. I'm going to take two more questions, and then we will, I see a very large group there. There's like 4 hands in a row, but I also see a woman right behind you, I believe. So I will come to the group, but if, yes, so I do practice the gender balancing question, so please.
Hello, everyone. I'm Linda Prato, medical student from Venezuela, and I have a question related to medical students. While we experience the resignation of healthcare workers, we also see an increase of health and including mental health issues amongst healthcare students. So they are dropping out of medical school. So do you have any suggestion on how to address this situation in our medical schools?
Great. Thank you for the intervention. I wanted to ask the row of 4. Is there one hand there? Okay. The gentleman on the left. Okay. Yeah, please.
Hi, everyone. My name is Isidore, originally from Nigeria, and I'm currently doing my master's in global public health here in Germany. So my question is very simple. I want to thank you all for acknowledging the problems why people leave. So now, how do we fix it? I come from a country where like almost 70% of the doctors have left to Dubai or here to Germany or the UK, and the government basically doesn't care. And we also have the issue where foreign trained doctors are being kind of discriminated. So you have your own trained doctors leaving, and then you have those that have already left with better training from abroad, trying to come back and practice and contribute their own quota. And they are being given harsh conditions to even get licensed. Some of them have to repeat their exams 100 times. There is no transparency. You just wait and receive a list. It's either you pass or you fail. You know, you can't prove to me that I failed. You can't show me the results of my exam. So it's a terrible problem. And the question is simple. How can the international community help towards this problem? Thank you.
Great, great. Thank you for that. I do want to get a colleague in the back of the room too. There's a hand at the very end that's moving. And then we'll come to our panelists and hopefully we can do another round. Yes.
Right. Thank you very much. My name is Dr. Ohineba Osudansu, coming from Ghana, from the second largest hospital in Ghana, Confirmatory Teaching Hospital. I think the issue of health workforce migration and resignation is a very critical one. It's been discussed over the years, and now we are seeing it more pronounced within the pandemic and after the pandemic. Clearly, this calls for action. And here I want to plead with the global community, especially leadership from the WHO, because I think we can actually gather statistics on the entire workforce population that we have and how they are protecting and serving the populations we have across the world. Because we have done a lot of interventions over the years. In Ghana, postgraduate training was a big problem. We have done a lot to introduce a lot of postgraduate training programs for pharmacists, doctors, and nurses for them to specialize. It stabilized the situation in the 90s coming to 2000s. Yet with the outbreak of the pandemic, we've seen a huge scale up of the migration. Why? Because the developed world is not training enough. They are not investing enough. And therefore, with the push and the pull factors, no matter the huge interventions you do in the developing world and in several areas, there's no way the economies can compare. So we need to really get a certain action that will look at the figures. And for those who are actually going away, if there can be a certain reparation to even resource the training institutions, because we are training a lot, but almost a huge number is leaving, especially after the pandemic, despite all the interventions to stem the brain drain. This calls for action because the population of the world must be protected.
Thank you. Thank you. The intervention there reminds us again about global responsibility, the flow of migration. The resignation is linked to and having a responsibility of high income countries. I want to turn to our panelists to respond, taking the conversation to how do we fix the system so it works at all levels? How do we make sure that the policies are ethical for human rights of our patients, the people, the communities we serve, but at the same time, the health workers? And how do we have this responsibility at all levels? So I'm going to turn to Dr. Rana first, and then we'll go through the panel, please.
Yes, thank you, Rupa. I mean, I think some of these questions can be better addressed by my colleagues, but I think it's always a balance. I mean, there are definitely national priorities that need to be taken into account, but they're also, we cannot deprive people from the opportunities to have a better life and better incomes. I think we do have an opportunity now. Maybe I want to bring to attention post-COVID, there's a lot of thinking happening. And as we all know, the world forgets very quickly. We call it in our public health word, we call it panic and neglect. We panic, we try to do things, and then, just shortly after the word has moved on, then we kind of forget about it. So the time really is now for all, I think for governments, but also for professional associations, for partners, for donors, to make sure as countries are now thinking about the lessons learned from COVID, building their health systems or rebuilding their health systems, putting together their recovery plans. There's a lot of discussion going on, and we're going to hear a lot about it in this forum at the World Health Summit. it is really critical to ensure that adequate attention is given to the health workforce. There is not going to be strong and resilient health systems without strong and resilient health workforce. It's just not going to happen. We need to make sure they have the right opportunities, they have the right pay, the right education opportunities, career progression, the right life, work balance, and all of this need to get adequate funding, adequate support. But as I've said at the beginning, having a strong health workforce is one of the 6 important building blocks of building health systems, in addition to financing, to providing essential services, access to medicines, etc. So this has not taken as much attention as it has done in the past. And I think this is the time now to take advantage, just at least in honor, as Howard said, I mean, in honor of all the people and all the colleagues who lost their lives during the pandemic. We cannot forget so quickly, and we need to make sure that we put together very strong plans and plan ahead of time. I mean, we don't have to wait until another pandemic hits to realize that we have a problem. So this is all about adequate strategic planning at the country level that I think we need as public health professionals, as civil society, professional organizations. We need to work with the governments. Governments have so many priorities right now. Economies are collapsing post-COVID, but we need to be there to keep reminding them about the importance of the health workforce. I will leave some of the education issues that were raised by the medical, because I think this is also within the education realm that some of these issues should be addressed as well. So.
Thank you, Rana. And I think what I want to really pick up on is the time is now. I mean, to see the room filled here, but to also share just, the Gender Equal Healthcare Workforce Initiative has seen incredible momentum. We've seen so many partners come to the table, but we've also seen is governments. And Rana, you're saying a very clear message here that governments are right now looking at how do they strengthen their health systems? How do they make them more resilient? How do they respond to the current pandemic or other crises they're facing? And they are recognizing that health workers are critical. We've seen at the World Health Assemblies that have passed resolutions on this issue. So now, how do we make sure that when governments are looking at these issues, that they're addressing the gender aspect, they're addressing the mental health aspect, the support aspect, they're looking at it from a systems component, they're looking at the complexities. I'm turning to you, to Howard, to pick up the solution piece. Like, what do we want these governments to be doing to address this?
So one of the things, I'm not sure if I'm allowed to do this, Rupa, because one of the people, a couple of people who you're recognizing tonight as heroines of healthcare, ICM was honored to nominate from the Swiss Nurses Association. And I want to say something about that, because I think that on a lot of these issues, the public may well be ahead of politicians. The Swiss Nurses Association, and if they're in the audience, Yvonne, excuse me for paraphrasing like this, the Swiss love a referendum. So they were able to instigate a referendum on investment in nursing. And the government said, you're only doing that because of the pandemic. And the Swiss Nurses Association said, yeah, of course we are, because look at what the impact has been and the inequalities and the decimation that there's been. And then they said, oh, well, we can't make a special case of nursing. And the Swiss Nursing Association said, here's all the evidence why you do need to make a special case for nursing on basis of the healthcare. Goes out to a vote of the population. And it's a really difficult vote to win, because you have to win it on a canton by canton, a county by county, as well as winning the overall public vote. And they did. They got 3/4 of the cantons and over 60% or whatever it was for the country vote, despite the government saying they couldn't afford it and they couldn't make a special case. Why was that? And I think that part of the reason is because, in the same way that when health systems fail, the people who have to deal with the consequences, we all saw the pictures from around the world. If there isn't enough oxygen, there isn't enough beds, there aren't enough ventilators. It's not the people who've made the policy decisions who have to eyeball patients and the public to make those decisions. It's frontline healthcare workers. And when those systems fail as well, if there aren't healthcare workers, who's going to do the caring? It's us, it's family, it's friends. So they see the consequences. So I think there is something about, firstly, associations and health workers not being afraid to be in the political space. I'm not calling for people to be partisan, but I'm saying it's a political choice. Get in the space and look at the allegiances, the alliances that there are with public and with patient groups as well, because I think that's a potentially really powerful.
Howard, I'm going to
point.
ask Sandra to chime in on that. So Howard's saying associations need to be more political. What do you think?
Oh, yeah, I totally agree. I think that's one of the actually, the strategies that we really have to look at, the associations. And of course, for us, as midwives, it's been a really good way to move forward, especially in Latin America and some other parts of the world. Because usually, if there's only one voice, it's hard to get it to know, but also we need more voices. But we're also facing the challenges of the new times where we need to know the technology, we need to get closer to the young midwives, because also the times are changing. And it's not like before, like when we were inside of a room. Right now, we don't need more walls anymore. I mean, we don't need the walls anymore because we have the internet, the connections, and that's the young ones. So we are also facing this challenge, that is how to bring the young ones to the associations, for example. But of course, for us, it's been a really important way to move forward. We've been approaching, of course, the government in our country. Thanks to the association, we've been, taking part in many different actions regarding sexual and reproductive rights, for example, the abortion law. Also, we're advocating for the first midwifery director. That is one of the fourth in the world, but of course, we're still waiting that the Minister of Health finally signs, the position. But we still advocating. So then I really ask myself, even though we, for example, in Chile, we have the midwives for 187 years, but then we say to ourselves, well, how come about 197 years? We still have to advocate for the profession. We still have to say that we are here to work for the women. There's so much evidence. When is this going to stop? We should be dedicating this time. Of course, we want the association, but we dedicating this time to the women, not to be, fighting, marching on the streets. I think there's also a way that we have to move forward. Associations are great for us, of course, to move forward in the profession, but we also need the politicians to listen and to look that, of course, we need to be there to work.
I want to pick up on what you're saying, and I'm going to be coming to you, Dr. Patient, really to, you're an evidence generator. You gave concrete examples. How do we make sure that evidence is getting into the hands of the policymakers? And policymakers are all of us in this room. I think everyone can be a policymaker and should be. And so how do we take this evidence that you're talking about and make sure, it's getting to WHO, it's getting to the associations, it's getting to the governments, it's getting to our leaders?
Yeah, thank you very much. So I think in academia, there's sometimes a false sense that once we do the research and we publish it, that is it, right? And so we're doing a lot of research and publishing, and it's going nowhere. I think this is one of the fora to make sure that the information is getting somewhere, having the right people in the room when you are sharing such information, having the right people hearing the message. But I also think really important is, and something we have tried to do, is try to distill our information in a way that the policymakers with a really short attention span can really get our information. So really distilling research funding into short briefs, into white papers. We have tried to do that with some of the research we did, generating policy briefs with this and trying to get it to the right hands. Sometimes it is a little disappointing because it's hard to know who the right hands are, that you identify people in policy who potentially should be able to make an influence and you keep being referred somewhere else. But I think getting to the point where first we are having clear information with recommendations that we are handing to people who could potentially cause change. Speaking to audiences that have the right. So an example is initially we present this at international conferences, right, where there probably aren't a lot of policymakers there, but then seeking out information, opportunity for local meetings where policymakers are likely to represent and going to present at some of those meetings. But I also want to make the point and about the fact that I think one of the ways to get this information into the hands of government is to make sure that government owns it, that they are the one who are sort of motivating this. And I say this from our experience. So this research project that we conducted, it started off as an unfunded research project. So early in the pandemic, we were hearing a lot of things on the social media. We're hearing our colleagues talk about it. And so I started asking, is there a research project going on documenting this? Like, is the government of Ghana documenting this, finding a way to listen to what healthcare workers are saying? And there was nothing going on. And so it was basically reaching out to colleagues saying, hey, we need to launch this survey. We need to find a way of documenting this information so we can hand it over. I think maybe it would have been more impactful if it had come from the other side. The government was investing in this and saying, we want to hear how our healthcare workers are feeling, what they're experiencing, and really taking the lead in some of this. And so the investment in research is really important, so that government is owning the information and working with it.
So
once that is not happening, we need to send it to them.
wow, there is so much to say. We are at time. I do want to give our panelists rapid fire. The take home call as we close out this session. We will be hearing from the government of France. But what would be your one ask of governments? We know the time is now. We've heard that. We know that this problem of the Great Resignation is taking place in high numbers. There are a lot of challenges to get it right. The ethical questions being raised, the intergenerational, the fact of having whole of society, whole of government, each actor here, academics, associations that spoke earlier, federations. So what's your one closing message? And then I will be calling on our government partner to join us and close us out. So please, Rana, to you first.
Yes.
Lightning round.
Yes, thanks, Rupa. The one message is invest in your health workforce. This is I think you're going to have the best return on investment in the long term. You cannot build or rebuild your health systems without building your health workforce. Invest in, not just financially, invest in their education and invest in their well-being.
Thank you, Dr. Rana. Yeah. Lightning round, Howard.
You've stolen mine because mine was invest, but change your mindset. Think about the investment in the same way that you do about national security, because that's what you're buying. You're buying health security and you're buying peace as well. And honestly, I believe the world's nurses need a pay rise as well. We haven't talked about pay, but I think working conditions are appalling in many places, and you can't get away from pay. Do you know, on average?
Sorry. Gotta cut you off.
Enough.
We will continue the deeper dive on pay another day, but point noted there, Dr. Patience.
Relatedly, I would say improve the work conditions of healthcare workers. Healthcare work is one of the most, if not the most meaningful profession out there. And people are unlikely to leave if their working conditions are improved. And so really improving the work conditions for healthcare workers.
Thank you, Dr. Patience. Sandra.
Well, I would say to the politicians over there that it really is the time to invest in health workers, invest in midwives, because women want competent and supported midwives, respectful and dignified care. So it's time. We are running late. Invest in health workers.
Thank you. For sake of time, I'm just going to ask our panelists to stay, and I invite the ambassador and Claire Amprou, future ambassador for global health, government of France, and the current pandemic treaty negotiator to close us out. The podium is yours. Welcome, please.
Honorable ministers and directors, distinguished speakers and guests, good afternoon, everyone. I'm very honored to be with you today and to represent the government of France. I take the opportunity to introduce myself. As you said, I'm currently the head of the French delegation for the negotiation of the pandemic agreement, but I was appointed just 3 days ago as the French ambassador for global health. Just a few. just a few words about my experiences. I worked for the French task force on Ebola in 2014 and 15. And more recently, I managed the task force on COVID-19. During these two experiences, I have witnessed how health and care workers experience a disproportionate burden of disease and health deaths, especially women and girls. And so thank you very much to all the speakers for the vibrant discussions on a very sensitive issue. Collectively, we must take up this challenge and make sure we avoid the great resignation and immigration of health and care workers that is looming over us. Because without human resources, health systems do not exist. And we know the challenge is above all political, and it is about time we all first recognize the work that these health and care workers do on a daily basis, simply saving our lives. Second, value the health and care professions, both in terms of perceptions and remuneration. Third, act as a grassroots level. That means on initial training in all countries, high, middle, and low income one, to guarantee the quality of health workers and allow access to health services for all. This is a challenge of the WHO Academy, which France has supported since the beginning, and therefore invest heavily in health, as you said. And I mean invest, not pay. Health is not a cost, but an investment. And by improving gender equality in the health and care sectors, it is a benefit to all, with the realization of a triple advantage in terms of benefits for health systems, equality between women and men, and economic growth. In France, a collective reflection called Ségur de la Santé was carried out and led to the commitment of 8.2 billion euros to improve working conditions in the health sector and to enhance the value of care professions. So let us prevent the great resignation of health and care workers, the consequences of which will be a disaster. At a time when countries around the world are negotiating for the pandemic agreement and creating funds to ensure that the world is better prepared for future pandemics, let us mobilize to act on the very essence of our health systems, human resources. France is committed and will remain so. So I thank you for your support. Thank you.
Thank you. And on that note, we close the session, but the action must continue together. We encourage you to check out the Gender Equal Healthcare Workforce Initiative. And if you're keen to join as partners, do reach out to us. Thank you.